Good morning, everybody. Thank you so much for being here with us for our August meeting. As the members of the task force know, we always begin our meetings by talking about where we are in terms of numbers and what's been happening. And we do that knowing, of course, that even one loss is too many. And also keeping in mind what we always say, which is when we do think about numbers, we think about the impact not just on a person who might lose their life from an overdose, but on their circle of family and friends and loved ones. And when we use even a very conservative number, that every loss affects 10 people, you begin to see how much that number increases. And when we are able to see decreases in that number, really as a result of the work of so many people on this task force, what the size of that impact really can be. And it really grows exponentially. And to that end, I want to talk about where we find ourselves now, more or less two-thirds of the way through the year. And it is, and I say this consistently, it is a place where 5 or 7 years ago, I would never have thought we would be able to get to. Because where we stand right now at this point in the year is that from January 1st of this year until just the other day, we have experienced 53 non-suicide opioid related overdose deaths across our county of 1.8 million people. And that, comparing to last year at this time, reflects a 39% decrease. And for those of you who've been with us for a long time and you remember for how long we labored and couldn't move that number, to be at that rate of reduction is really remarkable and is an incredible testament to the work that people are doing. The other thing that I'm extraordinarily pleased about is, we've talked a lot at these meetings about even as we have seen those numbers go down, what we were seeing was the number of opioid related deaths by suicide increasing pretty dramatically. And for the last year or so, that has really been a focus of our work. And especially considering the fact that we do not call an opioid death a death by suicide unless a very high bar has been met, unless there are notes, unless there's a clear indication. So it is certainly possible that some of those 53 deaths that we talked about, that we call accidental opioid overdose deaths, may in fact have been deaths by suicide. But again, really as a result of the work we've been doing here, we've seen that comparing year to year from last year at this time, we had experienced 13 opioid related deaths by suicide across the county. And this year we stand at 5. So that is obviously over a 50% reduction. It again really is a testament to the value of partnerships and the work of people in this task force and people across our county. So I know that I speak for so many people who have not experienced that loss, for families who have not suffered, in thanking everybody for the work that people are doing. And in that line, I'm sure you all know, August 31st is International Overdose Awareness Day. And this year's theme really coincides with what we say all the time. It is that one big family driven by hope. That is the theme. And it's just a reminder of what I talked about earlier, is the network of people that are affected. And we know that really no community has been unaffected. Um, and I also want to begin this morning by talking about some news from federal agencies. At the beginning of August, the Substance Abuse and Mental Health Services Administration released its data from the annual National Survey on Drug Use and Health. And that is the leading source of population based statistical data about drug use, about mental health, and other behavioral health information. And according to that survey, and I know sometimes we talk in numbers and percentages, and it kind of blurs in your head, but these numbers are really pretty startling. Um, that survey showed that for people over 12, so beginning with people age 12 in this country, 2.7% of them are misusing opioids. And 2.7 doesn't sound like a big number, but that 2.7 is 7.8 million people. And if you think about Middlesex County, we are at 1.8 million people. So it is several times the size of every man, woman, and child in Middlesex County. And that, as startling as that number is, the piece of good news embedded in all that is that that does reflect a 0.3% decrease from the year before. And the one piece that's not included in there is situations where somebody has used illegally made fentanyl. Um, a discouraging piece and something we know that's shown in this statistic is that, again, for people over the age of 12, of those people needing substance use treatment across the country, and we know we are somewhat better off here in Massachusetts, only 1 in 5 or 20% are getting the actual treatment that they need. So when you take that piece and couple it with what we know about the number of teenagers who are reporting poor mental health and the increase we've seen in that, particularly in the last 5-6 years, we know that many of them are turning to substances to self-medicate, and that pretty quickly that also often includes fentanyl. And in fact, in the period since the pandemic, from 2020 to 2024, of young people from ages 10, so think about that, ages 10 to 19, who suffered an overdose death, 75% or 3 out of 4 of them involved fentanyl. So education is an important piece. I encourage you to look at the materials, the really very good materials that the Center for Disease Control is produced. They have a Free Mind campaign directed both at parents and caregivers with resources. And there are really some very, very good resources. And I encourage you to take a look at that. They are downloadable and shareable to be used in your community. And another federal level update I want to highlight is that at the end of July, Health Secretary Kennedy announced a plan to restrict access to the kratom derivative that is readily available online and in vape stores. And once again, Middlesex County is a few steps ahead on that, as a number of our communities, including Lowell and Chelmsford, have already banned those substances. But the FDA is beginning a process to classify this derivative according to its risk for use and the accepted benefits. So I'm hoping that other communities, both in our county and across the country, will benefit from that. And turning to today's meeting, we're very fortunate to have 3 speakers with us to address some changing concerns and some new strategies. And we're going to begin by welcoming Ashley Witz. And I know many of you know Ashley. Ashley is the clinic director for the much touted and very successful Matador, which stands for Medication Assisted Treatment and Directed Opioid Recovery Program at the Middlesex House of Correction in Billerica. Ashley graduated from Salem State with a bachelor's and a master's of social work. She then began work at the Department of Children and Families, doing that hard work of trying to keep families intact by increasing resources and support. And she moved to a job as a mental health clinician at the House of Correction in 2016, and really could see the direct interaction of co-occurring disorders and the criminal legal system. And in 2023, she took on the role of clinic director and has been working to increase access to medication for opioid use disorder in a correctional environment. And Ashley's going to talk a little bit about the program and about the drugs they're seeing at the House of Correction, and share what the Sheriff's Office, always a great innovator, is doing to ensure the safety both of the inmates in their custody as well as corrections officers. So Ashley, thank you so much for being here.
Thank you so much for having me, DA Ryan, and thank you to your team as well for helping us coordinate this. K2 is still very new to us here at the Sheriff's Office, so having these platforms to talk about it is really crucial. I have a PowerPoint that I would like to transition to. Hopefully everyone is able to see it. Okay. All right. Are you able to see it?
Mm-hmm. Yes.
Okay, great. So again, my name is Ashley Witz. I am the Matador Program Director here at the Sheriff's Office. My topic today is synthetic cannabinoids and how we are trying to combat this problem in an incarceral setting. What is K2? It is the trade name for synthetic cannabinoids. It is a term used for a group of synthetic cannabinoids that are chemically engineered to bind to the same receptors in the brain as THC. However, they are not derived from the cannabis plant and can produce much stronger and more harmful effects than natural marijuana. K2 is one name for a group of synthetic cannabinoids. These drugs are human-made, mind-altering chemicals. A person can make K2 by spraying synthetic psychoactive chemicals onto dried plant material. In this form, people can smoke the K2 similar to how they might smoke cannabis. K2's effects can be unpredictable and more dangerous than cannabis. In some cases, K2 can put a person's life at risk. What are some of the other names for a synthetic cannabinoid? And I also made sure to capture various pictures of what K2 looks like in squares that are coming into the facility, and then how folks are using other objects given to them in order to smoke it. Other nicknames include K2, spice, fake weed, legal weed, squares, blaze, sheets, and snacks. The history of synthetic cannabinoid. John William Huffman was a professor of organic chemistry at Clemson University who first synthesized novel cannabinoids. His research, funded by the National Institute on Drug Abuse, was focused on making a drug to target endocannabinoid receptors in the body. Beginning in 1984, Huffman and his team of researchers began synthesizing cannabinoid compounds with THC properties for medical research purposes. Over the course of 20 years, Huffman and his team developed over 400 synthetic cannabinoid compounds, which were used as pharmacological tools to study endocannabinoids and cannabinoid receptor genetics. In the late 2000s, two of Huffman's cannabinoid compounds were found in street drugs. K2 and spice were being sold in Germany as marijuana alternatives. I figured once it got started in Germany, it was going to spread. I'm concerned that it could hurt people, Huffman said. Huffman may have developed these compounds for scientific research, but as of 2011, he was blamed for its abuse. The JWH series are certainly more potent and easy to make. Huffman believes it is a more widely used synthetic cannabinoid. What happens when a person uses K2? According to the Centers for Disease Control and Prevention, poison centers receive thousands of reports of adverse health effects in people who use synthetic cannabinoids each year. Similar to other recreational drugs, most K2 users are young people, with adolescents representing 40% of users. Males are more likely than females to use the drug. Individuals who use K2 commonly also misuse other substances such as cannabis. The name synthetic cannabinoids often makes individuals think of a synthetic version of recreationally legal, mostly safe marijuana. When a person takes K2, the chemicals in the drug act on cannabinoid receptors in the brain and elsewhere. These are the same receptors on which THC acts. When K2 acts on the cannabinoid receptors, a person may experience the following effects: elevated mood, relaxed feeling, altered perception of surrounding objects and conditions, psychosis, which involves delusions or the feeling of being detached from reality. Other effects include psychotic effects that a person may experience. This may include extreme anxiety, confusion, paranoia, even hallucinations, which are sensations and images that appear real even if they are not. Studies show that synthetic cannabinoids are associated with higher rates of toxicity and hospital admissions than natural cannabis. Synthetic cannabinoids have a stronger and longer lasting interaction with cannabinoid receptors than THC, leading to more powerful effects with an extended duration. Also, K2 and other synthetic cannabinoids often include different chemical compounds that can interact unpredictably with the receptors, causing dangerous effects. After using K2, some people may require emergency medical treatment. They may present with severe symptoms such as rapid heart rate, vomiting, violent behavior, and also suicidal ideation. Other common symptoms of K2 toxicity include agitation, drowsiness, high blood pressure, and confusion. K2 can be habit forming. If a person develops an addiction to K2 and then tries to stop using it, they may experience withdrawal symptoms similar to what we see with other habit forming substances. Now, what does K2 inside a correctional setting look like? Concentrated K2 is the most common K2 that we're seeing inside of Massachusetts jails. This can cause a cannabinoid overdose from a single hit that is smoked from a dose smaller than a human thumbnail. And you can see that in the picture to your right. Signs of K2 overdose include shaking uncontrollably, almost similar to a seizure, disorientation, paranoia, vomiting, rigid and frozen body, violent actions, growling, and also the inability to speak. There is no way to reverse a K2 overdose like an opiate or opioid overdose. Narcan can be ineffective for K2. However, as first responders, we will make every attempt to use Narcan, and we will always be using a multidisciplinary approach. So our providers as well as nursing is on site completing an assessment, which could then lead to an outside hospital admission. Doses of K2 and methods of distribution. There is certainly a market here inside of the jail and prison systems. You can see below squares. So most folks are taking a piece of paper, they're folding it in half, and then they are taking the K2, spraying it on it, and then divvying it up into squares. So one square equals one dose, and it is sold anywhere between $10 to $30 a square, depending on the supply. They may also create an ID of K2, and the name is after the paper being the size of an ID. You can see that in the middle picture, and it is worth anywhere from $300 to $600. A sheet of K2, which is an entire paper soaked in K2, is worth anywhere between $10,000 to $20,000. The sheet usually has inmate legal paperwork or case law printed on it. K2 has certainly become a silent drug epidemic and has been occurring behind the walls of the United States jails and prisons since approximately 2017. K2 is extremely difficult to investigate, detect, and litigate due to field testing and drug lab technology lagging and its inability to detect certain types of synthetic cannabinoids. K2 can appear to be a normal piece of paper and go undetected through the normal way that mail is being brought into our facilities. Most modern strains of K2 cannot yet be detected by a urine analysis. K2 overdoses can overwhelm security, medical, and mental health staff. Medical staff are not trained to detect K2 usage and usually treat K2 overdose mistakenly as a seizure. Patients are usually sent to an outside hospital for treatment. Staff can be assaulted by inmates that experience psychotic episodes as a result of K2 use. There have been anecdotal cases of patient K2 usage at the Middlesex Jail and House of Correction linked to severe episodes of psychosis that resulted in them being sectioned to Bridgewater State Hospital with permanent changes to the patient's personality as well as their mental status. what is needed to combat K2 introduction and usage. Narcotic field testing and urine testing technology needs to be updated to detect modern K2 compounds. Information and technology sharing between law enforcement agencies. It's recommended that joint investigations between the DA's office, the sheriff's departments, and the DOC take place. Sharing of new intelligence and new investigative techniques and methods. A lot of times within the criminal legal system, we tend to be siloed, and I think a multidisciplinary approach is certainly needed in order to combat this problem. Also, additional training to correctional officers, medical staff, and all personnel on how to identify K2 and potential use, and possible legislation. Push for the legislature to upgrade K2 to a Class A or Class B substance due to the danger it poses to the user and the danger the user can pose to the public while under the influence. And that is all I have for today. Thank you so much again.
Sorry, couldn't unmute myself there. Questions, comments for Ashley?
Ashley, do you mind sharing your slides?
Yeah, absolutely. Do you
Thank
want
you.
me to put them in the chat or send them to you?
If you could put them in the chat, that would be great.
Okay. I'm not very technology savvy, so I'll do the best that I can.
And if that doesn't happen, then feel free to just shoot them to me in an email. Thank you.
Okay, great. Thank you.
Anybody else? Ashley, that was great. Thank you so much.
Thank you again, DA Ryan. I appreciate it.
Of course. And moving to our next speaker, Rocky Miramontes is coming up on his first anniversary as the public health director for the town of Nantucket. And in this role, he oversees all of the public health and human services activities and initiatives of the Nantucket Health Department. As I said to him earlier, a very nice gig, especially in the summer. With 2 decades of experience at the Center for Disease Control and Prevention, Rocky brings extensive expertise in environmental health, infectious disease, epidemiology, program evaluations, and data analysis. And as a Center for Disease Control subject matter expert, he served in leadership roles in every major national public health crisis over the past 15 years. He is also a licensed physician's assistant with extensive clinical experience in family and urgent care medicine. And Rocky's joining us to share preliminary data from Nantucket's wastewater surveillance. And you remember we've talked a lot about this at the task force, about the folks from MIT who developed the devices for measuring opioids in the wastewater. So this is a great follow-up to that. So thank you so much for being here, especially as you're getting ready for a little Hurricane Erin on the island.
Yes, we are. And thank you for the invitation, DA Ryan. I'll go ahead and share a few slides as well. Let me know if you can see them.
Yep, we're good.
Perfect. Again, thanks for the invitation. My name is Rocky Miramontes, and I am on Nantucket. The weather's not great today, but we're by the weekend. Hopefully, it'll clear up. This initiative is really new to us. We started getting data at the end of June or so. Although wastewater surveillance is something we've been doing in conjunction with the state since 2022 with COVID, and we found that data helpful to us to provide alerts or advance notice of what might be occurring, at least with COVID on the island. And when we began this initiative, which we've been thinking about for a few months here, we also included flu and RSV as part of this. So as far as why we did it, I guess the first question I typically get, overdose deaths, of course, have risen nationwide. On Nantucket, there have been 19 in the last decade, and in a community our size, which is not large, It's not hard to run into just somebody that has been affected by substance misuse or overdose. And another important reason was our population changes. Our population will quadruple in the summertime. We go from 15 to 20,000 to 80,000 persons, including summer residents and visitors every summer. And so we wanted to understand, what the differences were in wastewater surveillance among those two groups, because we have the same number of resources regardless of the size of our screening for these substances. So and they're limited. Felt that the surveillance really augments our community partners' work. It's not designed to take the place of the important work that's occurring around surveillance, but we felt this data would be actionable and restricted to our local area, because we are on an island with one wastewater treatment plant. And as far as resources, we have one physician who provides MAT treatment. We have one counseling center. We have one small community hospital. So our resources truly are limited. We wanted to understand the best way that we can use them. So how this works basically is we draw just one single composite sample from the island's wastewater treatment facility. It's done at the facility. It covers approximately 70% of residents. We believe nationwide, I think that number is typically 70 to 75%. The other 30% or so are serviced, at least wastewater wise, by septic systems, which no system or no initiative that you put in place to be able to capture that. It's this community level. It's an anonymous signal, so there is no manhole surveillance that targets a specific neighborhood or individuals. I felt that was important for privacy. There are some larger jurisdictions. I know Houston, Texas it has a much more robust program, and they do manhole surveillance, primarily looking for infectious agents. So. And as I said, this is near real-time data. It's cost-effective, and it provides insights that really are designed to complement surveys in medical and pharmacy data, which are usually delayed in the reporting. So what the data, can tell us, signals received from infectious processes can provide advanced warnings of outbreaks. So we've learned that from COVID. And we pay attention to individual spikes. So a couple of months ago, we were looking at the COVID data, and we saw a big spike over just after Memorial Day, which was not surprising, but it enabled me to just pick up the phone and call the local hospital and speak to the medical director and let them know and share the data with them, so they were prepared for what might occur. And sure enough, within a few days, they saw a big influx of patients seeking care for respiratory type diseases in COVID. For high risk substances, which I guess what we're focused on here, and opioids, looking specifically or more closely at trends. So sustained multi-week increases are likely to represent an actionable event. Particularly in the summer, we'll see some spikes, but we were a little more looking for prolonged trends to guide us in our response to those events. And I think the other thing to make sure that I mention is that we're not trying to estimate numbers of users. That would require some assumptions, which I have done and thought about. But it would require assumptions like determining what the average dose is for cocaine, for instance, or the amount of wastewater created by each individual on the island. And there are estimates for those types of things, but we were not in a position to try and make assumptions. We wanted to look for trends. These are the substances that are monitored, and BioBot is the company that we contract with. They're a Massachusetts company. I think they're out of MIT, and maybe the same group that you were Dia Ryan was referring to. So these are the high-risk substances that we are able to capture screening surveillance for: cocaine, methamphetamine, fentanyl, xylazine, and illicit opioids, acetylfentanyl, carfentanil, heroin, tiapitine, and sufentanil, and prescription opioids as well: codeine, hydrocodone, and there's the lists there: oxycodone, morphine, and others. So really, we didn't want to put this in place without thinking about what those interventions would look like if we were to see spikes or those trends that I mentioned to you. So these are the types of things that we've talked through with some of our partners, things like targeted education, risks, stimulants to the body, clinical screenings, the potential for those providers that we share data with, including, for instance, for cocaine, maybe cardiovascular risk screening or mental health, depression screening. And then peer-led recovery groups I think are another important for a substance-specific product, because they change. Alcohol Anonymous is not the same as a peer group led and focused on cocaine or an opioid. And then we wanted to be able to increase access to Narcan, which is something we've been doing in the community here quite robustly. We're often offering classes on the use of Narcan and sharing it with groups. There's also fentanyl and xylazine test strips, which we don't do here, but all are aligned to our goals of harm reduction, health access, or getting that access to care, linkages to care when it's not on island, and building those partnerships even on the island and with those off island who partner with us on providing care. I've been asked a couple of times about advice for other communities considering wastewater surveillance, and this is, as we were thinking through this process or what we wanted to try and accomplish. These are the partners really that we worked with to help us, in our thought process. And one of them was, meeting with the wastewater treatment plant SMEs. They can have a lot of knowledge. That infrastructure is, some of the oldest in the country. It's also some of the most expensive. And how the flow of wastewater through a treatment plant occurs is an interesting process, and something that's important to understand when conducting wastewater surveillance. Engaging behavioral health partners early for intervention design, something we did. There are a number of resources, as you are aware, CDC resources. CDC also has centers of excellence, focused on wastewater surveillance in the Northeast. That is in New York State. I believe it's around Syracuse University. And then learning from other municipalities and what they are doing in academic publications. There's a number of academics who have published in this area. One in particular, I believe at Wayne State in the Midwest, who has published in the area of wastewater surveillance for opioids, and there's a lot out there to learn from. We released this data. This is, we still view this as preliminary data, but we released this data online, and in thinking through, when to release the data, we always knew we were going to release it widely and online, but we did it early. We wanted to ensure that we attached the narrative to this website, which it's actually on the website here, that really is focused on the things that I've just talked about, why we're doing it, why it's important, and help them think through what this potentially means. So you see that this is a summer, so it started at the end of June here, and this is a weekly draw or weekly event that occurs. And you can see it goes up and down for cocaine. It's in those blue lines and black lines are a regional average and a national average. So you can see, where we fall in each of these categories. The methamphetamine was very low. The nicotine was pretty consistent, and fentanyl was also low. And then as it goes on, this is high-risk substances that are psilocybin. You almost don't see it at all, and you just see the green line down there at the bottom. And then for this is prescription opioids. There is no, at least that the contractor had or could provide to us, a regional or national average. So these numbers are where they stand now. For a town our size, this is probably what's to be expected. But again, this is preliminary data. So as we have more trend data, particularly as we're looking at summer versus winter, we'll have a better idea of if we're seeing an anomaly in the data that we need to act on. And then there's just a few more kind of same thing, up and down with the different opioids here. And finally, I say this a number of times because we've gotten a lot of media attention, done some interviews, really trying to describe why this is important and what it is not. It's not manhole surveillance. We're not targeting a specific neighborhood. We're not trying to invade privacy. We are interested from a public health perspective in augmenting the already outstanding work that's being done by community partners in this area of treatment and prevention. And we really believe that this activity represents a good use of our finite resources and really the limited financial output that was required to undertake this initiative. That's all I have. That's my contact information if anybody wishes to reach out any more about this, but I'm also happy to take questions.
Reggie, thank you. Questions, comments?
So you mentioned the website. So is that where everything is available to the public?
Everything that you saw there that I had shared graphic wise is on the website. It's on our town website, our HHS website, and it also has the narrative that I talked about that we felt it was important to get out as part of this initial release. We will also share our flu data and our RSV data as that becomes more pronounced. At least the spikes are more pronounced in the fall.
Do you know anecdotally, like were folks surprised by what the data showed?
I don't think so. I actually had a conversation with the chief of police before I released the data and showed her the data, and this was not a surprise to her. It's important to understand. Anecdotally, we think what is occurring or what we hear in the community is what's actually occurring, but until we actually get some quantitative data, it's hard to say for sure.
Do you think the folks on Nantucket know what's available in terms of data? Like how widely spread is what's available on your website known, do you think?
Well, we shared it also via social media, and we put it on the town website. We've shared it as many different ways as we can, and I actually personally call the individual stakeholders when we have a change to the data.
Oh, wow.
So just because we're a small community, I can do that. And it also gives me an opportunity to talk about trends, what we're seeing, and they can also communicate back to us, what they are seeing, because it helps us formulate, what those interventions might be.
Great, thank you.
I just want to mention that the work that was done on Nantucket during COVID, there's one instance where, if you recall, the governor relaxed the masking mandate in Massachusetts and then brought it back very abruptly. And there's a slide that I use when I lecture nationally about masking that comes out of the wastewater from Nantucket, where there was a trend that literally the day 24 hours after the mask mandate was put back into place, the wastewater went. It was a straight down line, and that's how accurate the wastewater, and all of that went on during the COVID period was the people in Nantucket were following that on a daily basis. So they're all very, very aware on that island of their wastewater monitoring, and the work that Rocky and his team are doing it's been amazing all the way through. Even Rocky's predecessor, Roberto Santa Maria, was doing it during COVID, and everybody in that island watches it, and they're really very aware.
Thanks, Mike.
Yeah.
Anybody else? All right, Rocky, thank you so much. Be safe over there.
Thank you, ma'am. Have a good day.
Thank you. Now, turning to Stephen Murray, our next speaker. Stephen is the Associate Director of the Overdose Prevention and Director of the Safe Spot Overdose Hotline at Boston Medical Center. He's also an adjunct clinical professor of community health sciences at BU School of Public Health. And Stephen comes to that work with lots of different experiences. In 2013, he began working as a firefighter and a paramedic in Western Massachusetts. And in 2021, he retired as a lieutenant at a large regional ambulance service out in Western Mass. He regularly shares with a national audience about his lived experience, both as someone who has used drugs and who has survived an overdose. He provides expert technical assistance around the topics of overdose prevention, emergency medical services, workforce and harm reduction. And he does that to a variety of organizations, county and state governments. And he's also provided information to the White House Office of National Drug Control Policy. And, you know, we've had lots of speakers from that office. He's guest lectured at over a dozen universities. He's had research published in the International Journal of Drug Policy, speaking to all of those pieces that he brings to this. And he was featured in the multiple award-winning episode 809 on This American Life. And he's become a featured spokesperson for the Ad Council and the National Council for Mental Wellbeing's Start with Hope campaign. Stephen's here with us today to talk about trends in our drug supply and some of the new challenges that we are facing. You know, we've talked about this before. The opioid landscape is changing, and we're happy to have Stephen here to talk about some of those new things that he's seeing. So welcome.
Thank you, DA Ryan. I was remembering the last time I was here with you guys was to talk about xylazine in 2022, maybe, when it first came to the scene. So it's been a while since I've been with your crew. A lot's been going on. So I'm happy to be here and to see everybody. Thanks for the intro. I'm going to share as well because I'm a squirrel and will lose my place if I don't stay organized with slides. Okay. So, of course, nothing I'm saying represents any of the institutions I'm affiliated with. Don't hold it against them. Hold it against me. And as the DA shared, I have a pretty extensive background in overdose response. Is where I sort of came. Well, I started in this as someone who experienced overdose. I then progressed into overdose response, and now I'm thinking a lot about overdose prevention and detection. I'll talk about all those things a little bit briefly today. One of the things that I do like to just point out, I spend a lot of my time training first responders. So I train EMS around the country, mostly thinking around the working with people that use drugs from a lot of different angles, overdose being one of them. But I also talk about a lot of the other chronic health conditions that our populations are facing, and some of the ways that first responders can be more sort of helpful into providing a better level of care. And that is my sort of passion project, and I really enjoy doing it. My training is actually required now in like 4 different states for all EMS providers in the state. So something that I've been really pleased to get to spread around. And as she pointed out, and I've mentioned, I'm also a multiple overdose survivor myself. I like to show these pictures of me when I was actively using. These pictures are actually not long before I went to rehab. And so I think we often have an image in our minds of sort of what the average drug user may look like in the United States. And I think it's an inaccurate stereotype and a sort of belief as to what what we think we're seeing. And so this is me being a person that uses drugs. I was using opiates and meth in all these pictures, actually, and benzos in most of them. So just keeping that in mind, that the person that is at risk for overdose could be the person sitting next to you in your office today. I also like to do a little bit of level setting around this idea around overdose, addiction, substance use disorders, recovery, treatment. I think we throw around a lot of those words and sort of phrases and conflate them and interchange them. But I like to start by putting us that we're actually not in what I would consider an addiction crisis. We have had relatively, and I'll show you in a couple of graphs, steady levels of like diagnosed substance use disorders in the United States over the last couple of decades. But what we have seen is this massive increase in overdose. And in order to really think about overdose and think about it in a more like stepped back, wide angle lens, we have to remember that not all drug use is disordered. And so not all substance use ends in a disorder. Not all drug use is addiction. We see on the hotline in particular, which I'll talk about quite a bit in the end, we see drug use across the entire spectrum of use, whether it's from recreational, binge, experimental, all the way up through to like chaotic and problematic use that like would meet like criteria for a diagnosis. And drug use, this may be controversial for some people here, but drug use in and of itself, depending on the substance and where the sort of purity of substances and the experience of substances doesn't necessarily have to be as dangerous as I think that we think it does. The effects of criminalization, prohibition, making things illegal, etc., plays an important role in the relative risk of the substances that we associate as being dangerous. And then the other thing is that we see overdose across the board of people who use drugs, whether or not they have an addiction or not. And just to put into graphs here for you, when we look at like teen substance use, it's actually been relatively steady in terms of like what teens are doing using drugs. And actually, we saw a little bit of a downtick sort of in the COVID era. I have teenagers. I think that they're mostly addicted to their cell phones at this point. And I then contrast that with the graph on the left, which shows this sort of rapid rise over the same period in overdose death among the same population. So we're seeing the same or less amount of kids using drugs with this massive increase in overdose death. I think one thing that this shows us is that like prevention efforts do work. In terms of people using for the first time, et cetera, like those efforts are working. But we do see this sort of like huge increase in overdose death. And then we look across the whole population, not just children. This is the people with a diagnosed substance use disorder from 2015 to 2019. And you'll see there's actually relatively no change among all age groups across those years. But when we contrast that to deaths in the same period, we see this rapid rise from like 50,000 deaths a year up to over 70,000 deaths in that same sort of bracket. So just something to be aware of, something to think about. And the reason why I find that important is that if we think that all drug use is disordered, or we think that all overdose is a result of addiction, and treatment is sort of like the primary method that we're using to try to control that or try to fix that, we're really missing a huge part of the risk pool for people who are dying from overdose. And I actually will take it a step further, which is that I actually think that having an addiction or having a substance use disorder is protective from overdose. And we see this play out for a lot of different reasons. Why? Well, one, having a tolerance to the opioid supply is incredibly important to being able to deal with the fluctuations that we see in potency. So if you use every single day and you have developed this tolerance to the drug supply, if you have a bump, a 20% bump in the potency of what substance you're using, you're going to be much more equipped to actually deal with that potency shift as someone who is a naive user who may only use like once a week, and they take that at that 20% higher level what they took the week before, and that gets them. So I always think about it like when I was using opioids, if I were to take my morning dose right now of what I use today, like what I used back then, if I took that today, it would probably result in an overdose for me, but that's like what I call breakfast. So just a little bit of a thought on that. We can actually build sort of a tolerance in people using medications for opioid use disorder, like Suboxone or buprenorphine and methadone. And this actually does a really similar thing for them, which is to build this tolerance floor where their opioid receptors are either partially or fully being sort of like dealt with by these medications. And so those fluctuations are also a lot less dangerous. So if you have a substance use disorder, you're much more likely to have been placed on medication. The more you know about drugs, the more safe you or potentially could be, and understanding some of the risks that are going on. So, of course, with experience comes knowledge, and having a routine is also really important towards safety. The other thing that I think is hard for a lot of people to wrap their heads around is that when you know your dealer, you can build a level of trust with your dealer. And so having this like stable supply where like you see somebody that you know every day, like that dealer, if they trust you, is going to be more likely to say something along the lines of like, oh, be careful, this stuff is really strong, or hey, this stuff's weak, I'm sorry, like you're going to have to use more of it, etc. So that level of communication is also a safety feature. And so what ends up happening, what we see during arrests is that there's some new studies that I had in my slides, but I took out because I was short for time here. But we actually see overdose deaths increase in local regions after big drug busts. And so this is something that we really should be thinking about is like, how do drug busts impact local overdose death? Then, of course, like if you have a substance use disorder, you're much more likely to access harm reduction. Harm reduction is getting blamed for a lot of things that are going on around drug use in this country. Well, harm reduction is only accessed by, we think, less than 1% of drug users. And so it is one of those things where the more marginalized you are and the more severe your substance use disorder is, the more likely you are to have access to harm reduction. And so that is another feature of why a substance use disorder may be protective. Of course, if you're someone that is an experienced user, you're going to have experienced user friends. You're going to look out for each other. We had a tragic couple of deaths on the Cape earlier this year, or maybe it was last year. I have no sense of time anymore. But two guys used together on the beach. I think it was in Yarmouth, and they died together using. And if they had taken turns or they had spaced out their use, one would have realized that the other was having an overdose, and then something would have potentially happened. But instead, both of them ended up dying from an overdose. So the more experienced you are, the more likely you are to employ some safety tactics. So we hear about fentanyl a lot. It is still sort of like the dominant illicit opioid on the market, even though it's taken a much smaller share of the drug supply as compared to a few years ago. It's been mostly displaced by some other adulterants, which I'll talk about in a minute. But fentanyl, the reason why it was so significant is that it is really potent, which makes it difficult to measure. And when it's difficult to measure, that leaves a lot of room for human error when people are sort of like cutting down their drugs to then resell. The thing I like to point out is that because fentanyl is the only opioid that's primarily on the market, going up multiple levels within the chain, when we often talk about fentanyl overdose, you hear a lot of stuff around like fentanyl poisoning, or that it was like a malicious act by the dealer to sell somebody fentanyl. And really, we know through our data that that's just not the case. That's just what's available. It would be like if your liquor store only had vodka available and that was all they sold. And so that everybody who had to drank vodka. And we were surprised that, people were having much more severe outcomes from their alcohol use because the only available liquor on the market was one of the more potent ones. So keeping that in mind, like that's sort of the situation we've been in now for several years. And that does drive overdose death and has very little to do with sort of what your local run-of-the-mill dealer in your town might be having. The other challenge that we see with fentanyl is because it is so potent, minor amounts of cross-contamination can be deadly for people. So this is an example from Lynn, Mass. From 2022. It's just a really good example. This is how our drug checking data looks at MADS, which I'm on the advisory board for. So I look over all of our drug checking stuff as it comes through and help advise that team on implementation. This is an example of a sample that was sold as cocaine. And if you look, you'll see here that this sample was mostly cocaine. So the vast majority of the sample was coke, but there was a small amount of fentanyl in the sample. This sample in particular did result in a fatal overdose. So it was associated with like an adverse health event. And so somebody who was opioid naive taking this small amount of fentanyl died from an overdose. And so we've had this happen a few times. I have a video where I explain how this happens, but I cut it out. But basically what I'll say is that, say, for example, your dealer at your local level is selling both fentanyl and cocaine. They sell fentanyl to some people, cocaine to some people, and both to some people. If they were to cut the fentanyl on the table at the same time they cut the coke, small trace amounts of that fentanyl could find its way into the cocaine. And if someone who had no tolerance to the supply were to use that cocaine, they would potentially experience an overdose. I think this also happened when heroin was our dominant opioid, but heroin is so much less potent that small amounts of heroin would be negligible. And so you wouldn't experience an overdose as a result. Like all of us here could do a tiny little bit of heroin and we wouldn't have an overdose because it's so much less potent by magnitudes, huge magnitudes. So as I pointed out, the last time I was here, we were talking about xylazine. It started as an adulterant that we saw to the drug supply. We had a short time where it actually became sort of the dominant portion of the drug supply, especially in the Boston area. It's not a new drug. It's been around for a long time. It's been used by communities in Puerto Rico and Philadelphia for decades. We didn't know that much about it because it was never approved for use in humans, but it is a tranquilizer that causes very profound sedation. And from that sedation, we see a lot of different consequences, which I'm not going to get into all of them. What I do want to point out is that these environmental risks that we see with xylazine are really significant. So right now we're in the summer. Well, it doesn't feel like it today, but we're in the summer. And so if someone's using outside and they nod out in the shade, couple hours later, they may be in the sun and they've been in the sun for several hours. And so the risk of like extreme sunburn, heat stroke, et cetera, could be quite high. And so when we think about going into the winter, what we saw was that people didn't realize that they were outside for so many hours. And so they would be coming in with frostbite or hypothermia or freezing to death even from being out in the extreme. So they didn't die from an overdose, but they died from the impact of the substance on their ability to regulate their own body temperature. The other thing is that we see a lot of theft, assault, sexual assault associated with heavy tranquilizer use. I'd like to just point out, say DA Ryan and I are best friends and we use together all the time. DA Ryan may trust me enough to use fentanyl around me because I'm gonna maybe nod out, but if you poke me, I'm gonna be startled by it, or if I overdose, you'll do something about it. We have that level of trust. But maybe if we're using xylazine together, DA Ryan might be like, well, I don't really know Steven that well. Do I actually really trust him to be around him when I'm that sedated for 4 hours, and not waking up? That's a different level of trust that's needed between the two. And so when I look at some of the data, what I get concerned about is women in particular, LGBT communities. We may see, and we have seen potentially a lot more using alone in those communities because of risk of sort of these additional risk of being sedated. The other adulterants that we're tracking here in Massachusetts, this is a short list of some of the dominant ones that I'm going to point out. So Tinavin or BTMPS, we're seeing a lot of. It is all over the drug supply right now. We're going to put out an alert actually at MADS probably in the next couple of weeks. It is a chemical additive, but it has a lot of cardiovascular impact. So it's a calcium channel blocker. So we're actually still really unclear as to why it's being added into the drug supply, what benefit it produces. Normally, the drug supply is very logical. We can look at it and say, this adulterant is in here for X reason, whether it's to stretch product or to make it more potent or to increase the duration that, fentanyl is very short acting. Well, xylazine is long acting. And so that's part of the reason why it was added in. So we know that. With Tinavin, we're not totally sure what is the motivation here. We haven't quite figured that one out. The nitazines, we are definitely seeing some of that. It kind of ebbs and flows. They're seeing a lot of it right now in the UK and Australia and parts of Europe as the heroin supply is being pushed there. I do worry that with our fentanyl supply being under a lot of strain here in the US, that we're moving towards having an increase in nitazines in our market. just so you know, there's no drug called nitazene or nitazene. It's a family of drugs. So they range in potency. Some of them are less potent than fentanyl, and some of them are considerably more potent. So not all nitazenes are more potent than fentanyl, just some of them. And then all of the Xanax, fake Xanax that we see on the market right now is mostly bermazolam, which is a designer benzo. It's been around a long time. It is quite potent. So that's a lot of what we're seeing there. And then medetomidine is very similar to xylazine, and we're seeing that actually come in and displace xylazine in some ways as being sort of this like dominant tranquilizer in the market. We don't have a whole lot of data on its effects still. It potentially is causing different or more severe types of wounds, and it does potentially cause more profound bradycardia, which is like the lowered heart rate. So we've had some anecdotal reports of like people coming in after an overdose with a heart rate like in the 20s, which is quite concerning. So we think there's maybe a little bit more action there. The one thing I want to point out is from this drug sample here, this was a sample sold here in Massachusetts. It was a M30 Percocet, so it was like a fake Percocet, and it contained fentanyl, xylazine, bromazepam, and N-perlidino protonitazene, which is actually one of the most potent of the nitazines. And this was sold as a pill. And I worry about pills a lot because of the type of user who accesses pills is not generally like when I talk about that list of all the things that having a substance use disorder protects you from, that group is not using these pills at the same rate as our younger recreational folks of color, people who are, you know, experimenting, etc. That is something that I'm really, really concerned about. So that's definitely just something that's like heavily on my radar as like being problematic, is that the pill supply is just pressed powder, right? And so but there's this illusion of safety that a lot of people feel like when they see a pill that it's going to be more safe than accessing powder. So I just continue to point that out. So what does all this mean for us in terms of like overdose and overdose response? So just to review some of the symptoms of overdose. So I want to just also draw your attention to the difference between um, uh, symptoms of opioid toxicity and what are the indications to give someone naloxone, because they're actually slightly different. So when we look at like when someone is messed up on opioids, right, or intoxicated from opioids, having them have a decreased mental status, so being altered in some way, like unresponsive, that's usually a clue, right, that someone is potentially on an opioid. But what we're really looking for when we are thinking about giving naloxone are these symptoms, which are actually someone not breathing, someone who's breathing very slowly, and these then result in some other symptoms like hypercapnia, which is like when you don't offload CO2. But what we're really looking for is the absence of breathing. We're not looking for someone who's unresponsive as being our primary indicator. And the reason why that's important is that responsiveness is a symptom of overdose, but it's not actually the indication for naloxone. And in EMS, we use this mnemonic called AEIOU TIPS, which stands for all of these things. So these are all the things that we think about as EMS providers, as paramedics, as to why someone may be unresponsive. And so I give the example, like I used to show up on calls and it got called in as an overdose because it was a young person. And I get there and the police had given them Narcan and nothing had happened. And I realized that that person's breathing. And I'm like, oh, I wonder what's wrong with them. And I checked their blood sugar. It turns out that they're diabetic and their blood sugar is 14. Right. So because they were young and maybe they lived in like a rougher part of town and you know, there was like this belief that, oh, this was an overdose. Actually, it was a hypoglycemic event. And so that's one of the causes. So we like to think of like responsiveness as one of those things that it can be helpful, but also there are so many things that cause people to be unresponsive that it is not really a reliable indicator of overdose in and of itself. So we actually rely on breathing. The absence of breathing is much better indicator, clinical indicator, that someone is experiencing an opiate overdose, because opiates impact the ventilatory drive. How we move air in and out of our bodies is impacted by opioids. And so the indication for naloxone to reverse those effects would be like this depressed respiratory rate, the rate in which someone is breathing. And so that's important because when we then look at drugs like xylazine, which are not opioids, oftentimes people will be unresponsive, but they'll still be breathing. And no amount of Narcan in the world is going to bring that person back to being awake. And in fact, the more you give them, the probably more sick you're going to make them. And so remembering that breathing should be driving all of the decisions that you make around naloxone administration is really helpful to thinking about the context of adulterants in the supply. And so I always say, like, if someone's responsive, if someone's awake, that's a good indicator that they're not experiencing an overdose, because if they're awake, they're breathing, right? So if someone is awake, even if they're sedated and they're like, or like kind of out of it, they probably don't need naloxone because they're breathing adequately, they are awake. So when we think about xylazine, we are seeing people give way too much naloxone in our reports, thinking that they're like, oh, it took 16 doses to wake this person up. That is not the case. That's not how naloxone works. Naloxone is an incredibly potent antagonist. What that means is that no matter how potent the opioid is in your drug supply, 4 milligrams is actually still probably 4 milligrams, just like one nasal spray, is actually going to be overkill in most cases. I, as a paramedic, have used 0.5 to 1 milligram of naloxone to reverse every overdose that I've attended to in the last decade. It is not actually necessary to give more naloxone. We often see way, way, way too much given. So, something to think about. The other thing is that we often see repeat dosing happening way too quickly. So, the guidance by our state is 3 to 5 minutes. That feels like an eternity in between dosing. 3 minutes when someone is not breathing well feels like an eternity. But before giving that next dose, we really need to encourage people to reassess that person. In that 3 minutes, has their breathing resumed? Has it improved? Are they now breathing 8 times a minute? Is their color better? These are all indications that, like, you've given enough naloxone and that they may remain unresponsive going forward. We can't expect that people are going to wake up from overdose the way they did when we only had fentanyl in the supply, because that's just not what our drug supply looks like today. The other thing that we're really missing the boat on a lot is that when people wake up from an overdose, it's a really challenging time where often a lot of really shameful, harmful things are said to people. They're shamed, they're made to feel guilty about their situation, they're yelled at, they're accosted by police, they're mistreated by paramedics, etc. And I like to think about it as like one of those times where, like, when you come to, like, we want you to be coming back to an environment that's very therapeutic, calm, nice, collected. And that is going to be your best shot for having somebody who wants to maybe make any sort of change in their situation, is by having them come back to like a more pleasant environment. Otherwise, if you think about it, like, you're going to activate their fight or flight response, and they're going to go into like a shutdown mode because they're being yelled at or shamed or whatever. Now, we know that the first thing that people are going to do after an overdose is use again because they need to get out of withdrawal. And so if that person is not planning on starting buprenorphine, going on methadone immediately, et cetera, that person's main priority is going to be to get out of withdrawal. And so it's really important that we develop systems that take that into account and try to help keep that person safer. Now, one of the things we do is Narcan leave behind in most places. That's important because then their bystander can help deal with the next overdose that may happen. The next thing, though, is that if that person is going to be alone, you need to pick up the phone and put them on the phone with us. We will stay on with them while they use the next time to keep them safe. It's a high risk use event, and we are concerned about them in that situation. And so, finally, to talk about SafeSpot real quickly, we know that fatal overdose occurs primarily within a private residence. Very, very high percentage, like in Rhode Island. Massachusetts, we're hoping to recalculate this because I actually think it's higher than this. But what that means is that people are dying in their homes. I'm sure DA Ryan spends a lot of time looking at overdose death data and overdose death reports. As one of my really good friends was the DA in Berkshire County for many years, and we used to talk a lot about the overdose death reports that would come in. And she told me, it's like every day someone dies in their home, someone dies, in the bathroom upstairs while the person is downstairs. Like, this is what's happening every day. Fatal overdose happens in a private residence. So we developed SafeSpot as an alternative way to keep people safe, because it is pretty simple and straightforward. You call the 1-800 number. Our average hold time this week is 10 seconds. before being connected to an operator, 10 seconds. I don't know any service that you call that gets on the phone with you in 10 seconds besides 911. And we hang out with you while you use. And in case of an overdose, which is pretty unlikely given our stats, we are able to activate the EMS system for you. We don't store your name or address in our system. That stuff is kept between you and the operator. We don't collect any demographics like age, date of birth, gender, race, ethnicity. We do hold on to some of the stuff that happens on the call just for our data reporting, but it's anonymous and confidential. We've taken more than 10,000 calls since we started tracking data in the beginning of 2023. We just hit 10,000 like a couple days ago. We've supervised more than 25,000 use events. So 25,000 times people have used on the phone with us, and we've only had to call EMS 26 times out of those 25,000. So overdose is incredibly rare. When it does happen, we get them help, and all 26 of those overdoses had a successful outcome. So we know it works. It works really well. What we do a lot of is spending time on the phone with people. We've spent over 5,000 hours on the phone with people. Our average call is about 27 minutes. So we're spending a ton of time on the phone with people, offering them a sense of safety, security, value, etc. If you are working directly with participants, which I think a lot of you do, please pick up the phone with your participants and call us. You can do it 24 hours a day. Doesn't matter where you are or what's going on. You can do this at 3 a.m. if you are working in EMS or a police officer. Pick up the phone, call with them, get them comfortable with calling us. Our operators will explain to you how it works, how to get someone, how the intake works. And some things you can think about with people, like say you're working with a client or a participant and you're like, I know you normally use with Jeff. I like, what happens when Jeff goes to the store, or like what happens when Jeff goes to work? Who you use with during the day. And then what has the hotline taught me about working with people who use drugs? I think it's really wonderful that we're able to offer people safety without conditions. We're not trying to get them into recovery. We're not trying to get them into treatment. We're not trying to fix them in any way. We're really just trying to keep them safe in that moment, in that usually 27-minute window. And so that is one of the really great things about that. I like to contradict this idea of like the opposite of addiction is connection, because we are connected with people who have addiction all the time and having wonderful, like, fulfilling conversation with them. I think the opposite of connection is isolation, which a lot of people who use drugs do because they don't have this kind of environment to be in. And so if that is something where like you're experiencing that in your own life with someone, trying to build that connection without having to solve the addiction portion, I think is a really useful skill to bring away from what we've learned, at least. And of course, my DMs are always open. Please reach out if you have questions. Yeah, happy to take questions or talk more offline as well. And hope you learned something. Thank you.
Stephen, I have a question. This is Alice Casey. Thank you for
Yes.
that great presentation. Towards the beginning, you showed us a slide of the youth and how the percentage of youth using has gone down, but the deaths have gone up. So could you share with us what the source of that data is?
Yes. The U.S. students reporting any past year illicit overdose is not from NIDA.
Okay, great, thank you.
Yeah. A lot of that comes from the they do like the annual teen. Well, I don't know if they're going to do it this year. They've done it for the last 20 years. The annual survey of teens. So hopefully they do it again, because it's good for us to know sort of what's going on with teenagers.
Thank you.
Yeah.
Great.
And the death data comes from CDC.
Okay, thank you.
Yeah. I see a question from Julie about staying with a person on. So one of the interesting things about fentanyl is because it has such a short duration of action, and it's actually it's basically the only major opioid in our supply. The likelihood of re-overdose after naloxone wearing off is quite low. So a lot of that guidance comes to us from the era when we still had like Dilaudid in our supply. Like Dilaudid is a very long-acting opioid that lasts, it's why it's so useful in the hospital. Lasts like 4 to 6 hours. Heroin, which is a morphine derivative, like that has a much longer half-life or much longer duration of action. Fentanyl's duration of action is really like 15 to 40 minutes, depending on your metabolism. Naloxone is more like 30 to 60 minutes. And because of the peak of fentanyl and when it comes down, it's actually quite rare for people to re-overdose after from the same initial dose. I think what actually happens here is that, as I pointed out, like the thing you're going to do after you get naloxone is want to use again. And so what happens a lot is that people experience an overdose, they get naloxone, they don't go to the hospital or whatever they're going to do, everybody leaves them, and then they're in withdrawal, and so they use again. And that's a really high risk point. So our goal generally with when we have people who have had an overdose and we're getting them out of withdrawal is we're going to first wait out the clock on the naloxone with them, and then we're going to get them through their next use event safely. So we try to get them not to use until sort of that 30-minute mark after the naloxone's been given. Once they've gotten through that, then we do their next use event and we sit with them through that next safety window that we use. And then that usually has enough confidence that they're going to be good, and it's worked for us in the past. That's a great question.
Thank you. Very informative answer. Do we have any other questions? Oh, Marion was knocked off, but she is jumping right back on. Just bear with us for 1 second. So Marion, I don't know if you can hear us. We just finished with questions for Stephen, so he's just about wrapped up.
All right. Thank you so much. Thank you, Stephen. That was great data. People have no other questions, comments in general on our speakers? All right, seeing none. Just a reminder as we head into back to school and fall, and we have lots of Narcan test strips available. Feel free to reach out to us if we can be helpful with that. And enjoy these last couple of weeks of summer. Take care. Thank you, everyone.
Thank you.
Bye.